I want to start with something that many caregivers experience but rarely talk about openly. There are days when the person you're caring for seems almost like themselves. The conversation flows, they're calm, they're present, and for a few hours, caregiving feels manageable, even meaningful. And then there are other days when they're agitated before breakfast, angry about something that makes no sense, pacing the hallway for hours, suspicious of your intentions, refusing the routines that went smoothly yesterday. Days when you find yourself wondering whether you said something wrong, did something wrong, missed something. Days that leave you depleted and confused and quietly heartbroken. If that variation is familiar, if the unpredictability is one of the hardest parts of what you're navigating, I want to say something clearly right at the start. The variation is not your fault. The good days are not because you did everything right. The hard days are not because you failed. Both are features of how Alzheimer's disease affects the brain, and understanding why the behavior changes happen, not just that they happen, is the foundation for responding to them with more skill, more confidence, and more self-compassion. Today, we're drawing from the National Institute on Aging's guidance on managing personality and behavior changes in Alzheimer's disease. This is among the most practically useful guidance in all of Alzheimer's caregiving literature, because behavior changes are what caregivers encounter every single day in every stage of the disease. And I want to build towards something specific today. There's a finding in this guidance about what's actually driving most of the difficult behaviors, a layer beneath the obvious explanation of the disease that most caregivers never fully grasp. And when you grasp it, it changes not just how you respond, but how the situation actually feels from the inside. Stay with me. Let's start with the foundation, because the most important sentence in all of Alzheimer's behavior management comes from the NIA, and it is this: the disease, not the person with Alzheimer's, causes these changes. That sentence is short, it's simple, and it is genuinely difficult to hold on to in the middle of a hard moment, when someone is shouting at you, or pacing relentlessly, or accusing you of something painful. The intellectual understanding that the disease is responsible doesn't automatically protect you from the emotional impact of being on the receiving end. But returning to that sentence, repeatedly, consciously, as a deliberate practice, is one of the most protective things a caregiver can do for their own well-being. Not because it erases the difficulty, but because it prevents the misdirection of hurt and frustration toward a person who has no agency over what's happening. The behavior is the disease expressing itself through the person. The person is still there. They are not choosing this. The NIA identifies a significant range of behavioral changes that Alzheimer's can produce: anxiety and fear, increased anger and upset that can appear with very little provocation, depression or withdrawal from activities the person once enjoyed, hiding objects or believing others are hiding things, imagining things that aren't there, suspicion and distrust, constant pacing, unusual sexual behavior, wandering away from home, physical aggression, misunderstanding what they see or hear, severe sleep disruption. That is an extensive list, and encountering any one of these, let alone several simultaneously, is genuinely demanding. Knowing that all of them are recognized, documented features of the disease provides important validation. You are not dealing with something unusual or uniquely difficult. You are dealing with what Alzheimer's does. Now here is the layer that most caregivers miss, and this is where today's guidance becomes genuinely transformative. Not every difficult behavior in a person with Alzheimer's is caused by the disease itself. The NIA is specific. Other factors that have nothing to do with brain disease progression, can trigger or significantly worsen behavioral symptoms. And these factors are often addressable, which means the behavior is not inevitable. It may be reducible, if you know where to look. Here's where most people get it wrong about Alzheimer's behavior. They observe a difficult behavior, attribute it entirely to the disease advancing, and focus their energy on managing the behavior as a fixed feature of the situation. They don't investigate whether something else is driving it. The NIA's guidance says to ask a different question first. Is this behavior caused by the disease itself or by something else? The list of something else is specific and important. Unmanaged pain, which a person with Alzheimer's may be completely unable to communicate verbally: hunger or thirst, constipation, problems with vision or hearing that are going unaddressed, lack of sleep, emotional states, sadness, fear, stress, confusion, that have no adequate outlet, a noisy or overstimulating environment, the side effects of a new medication. Any of these can produce behavioral changes that look, from the outside, exactly like disease progression: increased agitation, withdrawal, resistance, aggression. And if the actual cause goes unidentified, the person suffers unnecessarily, while the caregiver manages a behavior that could potentially have been addressed at its root. This is why the NIA specifically recommends that sudden or rapidly fluctuating behavior changes, especially following an infection or recent medication change, be brought to a doctor's attention immediately. Sudden changes are a red flag. They are rarely just the disease shifting overnight. They are usually a signal that something treatable is happening. Let's talk about tracking, because this is a practical tool that most caregivers don't use, and that can make an enormous difference in identifying what's driving difficult behaviors. The NIA recommends keeping track of behavioral changes over time, not in an elaborate or burdensome way, but enough to allow you to see patterns. When does the agitation typically occur? What time of day? In what settings? After what activities? Before or after eating? When there are visitors? When the television is on? Patterns are information. A behavior that reliably appears in the late afternoon may be what's called sundowning, a recognized phenomenon in Alzheimer's where confusion and agitation worsen as the day progresses. A behavior that reliably appears after certain visitors may be a response to something about those visits. A behavior that appears when the television is loud may be a response to sensory overstimulation. When you bring these patterns to the healthcare team, they have something to work with. Not just a description of difficult behavior, but a map of when and where it occurs, which is the foundation for understanding what's driving it. Let's walk through the most effective management strategies. And I want to frame these not just as techniques, but as a coherent philosophy of care, because understanding why they work is what allows you to adapt them when specific situations don't fit any script. The first principle is environment, and this is genuinely underestimated as a driver of behavior. The NIA recommends creating a comforting home setting by reducing noise and clutter and keeping familiar, well-loved objects, photographs, meaningful items in the living space. This is not just about aesthetics, it's about cognitive load. A person with Alzheimer's is already working hard to process and navigate their world. A noisy, cluttered, visually complex environment adds to that cognitive demand in ways that contribute directly to agitation, confusion, and behavioral distress. Reducing that load, by making the environment quieter, simpler, and more familiar, directly reduces the conditions that produce difficult behavior. You're not managing the behavior after it happens. You're reducing the likelihood it will happen in the first place. The second principle is routine. The NIA recommends keeping the person to a consistent daily schedule, bathing, dressing, eating at the same times each day. Routine is not a small comfort for a person with Alzheimer's. It is a cognitive scaffold. When the sequence of daily events is predictable, the person doesn't have to figure out what's happening next. The routine carries them. And when the routine breaks, when meals are delayed, when activities happen out of order, when the schedule is disrupted, it creates the kind of disorientation and uncertainty that fuels behavioral symptoms. Protecting routine is one of the highest leverage investments a caregiver can make. The third principle is physical activity. The NIA specifically mentions that finding ways for the person to be physically active can improve both mood and sleep. We've discussed throughout this series how movement supports brain health and emotional regulation in older adults generally. In a person with Alzheimer's, those benefits remain real. A daily walk, gentle movement, simple physical engagement, these contribute to a calmer behavioral baseline. And they address two of the most common behavioral challenges, agitation and sleep disruption, through a single, accessible intervention. We're now at the section of today's video that I've been building toward, and I want you to stay for this, because everything I've said so far the environment, the routine, the physical activity, the tracking, is useful and important. But the insight I want to offer now changes how you experience these strategies from the inside. It's about what difficult behaviors are actually communicating. A person with Alzheimer's who is agitated, pacing, resisting, or acting in ways that seem inexplicable is rarely behaving randomly. They are, in almost every case, communicating something, a need that isn't being met, a discomfort that can't be named, a fear or confusion that has no verbal outlet. The pacing is often anxiety expressing itself through movement. The resistance is often fear of something unfamiliar or threatening. The aggression is often a response to feeling overwhelmed or cornered. The hiding of objects is often an attempt to maintain some control in a world that increasingly feels uncontrollable. The NIA's guidance on redirection, moving the person's attention to a new activity or object, to music, to a walk, to a familiar photograph, works not just as a distraction technique. It works because it offers an alternative channel for whatever the person is experiencing. Music provides emotional regulation. A walk provides movement for anxiety that was expressing itself as pacing. A photograph provides familiarity and connection in a moment of disorientation. You are not suppressing the behavior. You are responding to the need underneath it with something that actually addresses it. This reframe, from managing behavior to responding to communication, is one of the most humanizing shifts possible in Alzheimer's caregiving. It positions the person as someone still trying to express something, still having internal experience that deserves a response. Not as a behavior problem to be controlled, but as a human being whose distress deserves to be met with compassion and creativity. That shift doesn't make the hard days easy, but it makes them different, and it sustains the caregiver in ways that pure behavior management never can. Now let's address safety specifically, because some behavioral symptoms, wandering in particular, carry immediate physical risk that requires practical, proactive measures. Wandering is among the most dangerous behaviors in Alzheimer's caregiving. A person who wanders may not know where they are, may not be able to find their way back, and may be completely unable to identify themselves or ask for help. The NIA is clear. Ensure that the person always carries identification or wears a medical bracelet with contact information. Always. This is not a suggestion for when wandering becomes a pattern. It is a precaution to implement now, before a wandering incident occurs, because the first incident may be the one that results in a crisis. Rummaging, going through drawers, cabinets, and belongings, is another behavior that can create safety risks if the person accesses dangerous items. The NIA recommends locking up or placing out of sight and reach anything that could cause harm: medications, sharp objects, cleaning products, car keys, anything that could be dangerous in the hands of someone who is confused about what it is or how to use it. These safety measures are not about restricting the person's dignity. They are about protecting someone who can no longer reliably protect themselves, and doing it in a way that is discreet and preserves as much normalcy as possible. Let's bring everything together with practical actions. The first is to start investigating before attributing. When a new or worsening behavior appears, run through the checklist before accepting it as disease progression. Is the person in pain, hungry, thirsty, sleep-deprived, in an overstimulating environment, on a new medication? Has there been a recent infection? Investigating the addressable causes first often reveals something that can be improved and spares both of you from unnecessary distress. The second is to audit and simplify the environment. Reduce background noise. Turn off the television during meals and during periods when the person is typically most agitated. Reduce visual clutter. Keep familiar, meaningful objects visible. Make the sensory environment as calm and predictable as possible. These changes cost nothing and reduce behavioral distress in ways that are consistent and meaningful. The third is to protect routine as one of your most important caregiving tools. Same wake time, meal times, bath time, bedtime, every day. When disruptions to routine are unavoidable, prepare the person gently and in advance where possible. Recognize that disrupted routine is a common trigger for behavioral episodes, and account for that when scheduling and planning. The fourth is to implement safety measures proactively. Medical identification on the person at all times. Dangerous items secured and out of reach. door alarms, or other wandering safeguards if wandering is a concern. These protective steps are most effective when they're in place before they're urgently needed. And the fifth is to practice the reframe daily. When difficult behavior appears, return to the sentence the NIA offers. The disease, not the person, is causing this. And then go one step further. Ask what the behavior might be communicating and what need might be underneath it. This is not always answerable, but asking the question shifts you from reactive management to compassionate response. And that shift changes everything about the quality of care you provide and the experience of providing it. Here's what I want you to carry with you from today. Behavior changes in Alzheimer's are not random, they are not personal, and they are not always simply the inevitable march of disease progression. They are a language, imperfect, difficult, sometimes frightening, through which a person who has lost other means of communication is still trying to express something real. Your job is not to stop the behavior. Your job is to understand it well enough to respond to what's underneath it, with patience, with creativity, with the environmental and relational tools that research tells us actually work. Some days you will do this beautifully. Some days the behavior will exceed your capacity to respond with grace. Both are true of anyone doing this work. The goal is not perfection. The goal is consistency, showing up again, bringing what you know, adapting as you go. You are learning a demanding and nuanced skill in conditions that don't allow for much margin. The fact that you're here, seeking to understand rather than simply to cope, says something important about the kind of caregiver you are. Keep learning. Keep asking the question underneath the behavior. Keep returning to the knowledge that the disease is the cause and the person is still there. Before you go, here's something I want you to think about for our next conversation. We've spent considerable time now on what happens inside the caregiving relationship, the behaviors, the responses, the daily strategies. But there's a dimension of caregiving that operates at a different level entirely, one that affects everything else, and that rarely gets direct, focused attention. It's about caregiver identity. Specifically, what happens to a person's sense of self when caregiving becomes the dominant organizing force of their life. When your own needs, your own relationships, your own activities have gradually given way to the needs of the person you're caring for. And what the research says about recovering yourself, not after caregiving ends, but while it's still happening. This is one of the most underexplored areas in caregiving research, and it has real, specific, actionable implications for how you sustain this role without losing yourself in it. That's coming next. And if you want to be there for all of it, if you want to keep getting honest, research-grounded, compassionate guidance on aging and caregiving with clarity and dignity, subscribe to this channel. Take very good care of yourself. The work you do every day in moments large and small is among the most human things there is, and you deserve to know that.